So welcome. I'm Josh Korsnick. I appreciate Mutinga's introduction, but I wasn't able to hear it because the way this works, so I can't dispel any rumors, but I appreciate the introduction in any event. In this sort of surrealistic world we live in right now, this particular talk is really meant as an interactive discussion. And unfortunately, we won't be doing it that way. We'll have time at the end for conversation and questions. So I hope you're all comfortable at home. This is probably the first time I put on a tie for a long time, so getting used to all sorts of things. But glad you're there. It's a little bit like playing baseball without anyone in the stands. But in any event, welcome. These are my disclosures in terms of research support and other elements. And we're going to start with a series of cases is what we'll be going through today that have a variety of topics. My main focus is inflammatory bowel disease, so they're weighted a little bit towards that, but we have general GI as well. So we're starting with a 42-year-old woman who has a history of Crohn's ileocolitis for 4 years. Initially placed on steroids, 6-MP, 6-mercaptopurine was tried, but she developed pancreatitis, which happens in about 2 to 4% of people. Usually when it develops, it happens within 3 weeks, sometimes up to 8 weeks, and it usually doesn't happen if you've been on it for a long period of time. She was then started on infliximab. On presentation before starting infliximab, she had diarrhea and bilateral hip pain, and that resolved on initiation of infliximab. And she's been consistent in getting infliximab 5 milligrams per kilogram, which is our standard starting dose for inflammatory bowel disease, every 8 weeks. She has a past history of hyperlipidemia on atorvastatin, and she comes in complaining of diffuse arthralgias. So the questions to think about then is, what are the questions for her, and what are the things that you'd be thinking could be the issue here? And certainly one of the issues is, what's the nature of your joint pains? And now it's more diffuse than what she had before. Before, when she presented, as I mentioned, she just had her hips. Now she has hips, knees, ankles, and really, she said every joint in her body. She's not having any GI symptoms. Those are still continuing to be well, no diarrhea, no abdominal pain, no sense of urgency. And she's had joint pains to include now her hands and wrists, and she said really it's every joint in her body. The physical exam was normal, if we remember what physical exams are. So she has arthralgias. She doesn't have any arthritis. So the question is now, excuse me, how do we sort that out? And how do we make sense of this? So on presentation, she had just hips when she had significant GI symptoms. Now she has no GI symptoms, but she has a much more diffuse set of arthralgias. So how do we figure this out? So what's our differential diagnosis? Well, the very first thing is certainly, is it IBD-related arthropathy? So that's certainly a concern. That can happen in 20 to 40% of people. It tends to be more the larger joints, the hips, the knees, the ankles, less commonly the hands, and it tends to be the extent of involvement, whether it's ulcerative colitis or Crohn's. There is a correlation, particularly colonic extent, and it tends for the most part to be go along with flares of the disease. So when the disease is doing bad, when there's a lot of GI symptoms, the arthritis can be bad. It's not always that way, and sometimes arthritis can be sort of the herald symptom or a warning flag that something's going on. And the spine can be a little bit of its own world. Questions whether this could be drug-related, whether it's atorvastatin causing more of the joint pains or more muscle aches, or could it be infliximab? Is it non-inflammatory? Are we really missing the boat here and it's really osteoarthritis? Well, that would be odd. She's 42 to have such diffuse osteoarthritis. suddenly would be a little bit unusual? Or could we be missing the boat altogether in terms of thinking it's one of these first things, and is it something else such as Lyme or some sort of viral prodrome? And certainly in the age of COVID, which can present in so many different ways, that's certainly first and foremost in our minds. So what do we do next? We want to find out, is there disease activity? And probably the best thing we have is calprotectin. If there's arthritis or arthralgias from other causes, some of the things we rely on for inflammatory markers such as CRP is very nonspecific and not so sensitive for ulcerative colitis. Typically, even with a big significant flare, sometimes CRP can be flat normal. And with Crohn's, it's a little bit better, but it may be 40% of the time when someone has significant disease activity, it may be normal. And then there's a smaller percentage of people who don't really make significant CRP at all, maybe 5 to 10%. So calprotectin is flat. So that's the neutrophil marker that's in stool that's quite sensitive, that we're relying on increasingly. There's not yet a home kit, but there will be a home kit, hopefully in the near future. The Europeans have that, but it hasn't been approved yet in the United States. One of the things we worry about in terms of drug-related is, certainly could it be something else, rheumatoid arthritis. And then we worry about a lupus-like reaction that can happen commonly or not. Commonly, you'll get an elevated ANA and double-stranded DNA in people on an anti-TNF. So a low level of titer will be positive with an ANA in about 60% plus of people. So that's very important to know, because if they're having arthritis, you're worried that it could be a lupus-like reaction to infliximab, which the true lupus-like reaction happens perhaps 2 per 1,000, but about 40 to 60% of people have a positive ANA, usually at lower titers, and an anti-double-stranded DNA will be positive 20% plus in all comers without the symptoms even. So these tend to be lower titers as well. So they're still helpful to get, even though they might be confusing, because you'll say, oh, it's positive, we have a diagnosis, but if it's at a very low level, as will happen with many people, that's not confirmative of the diagnosis. Again, ANA positivity, these are conservative numbers. In infliximab, as much as 46%, adalimumab 19%, and even certolizumab is about 8%. This is the most conservative numbers. Some are much higher than what we have here. And just to review quickly, the adverse events that we worry about with anti-TNF treatment, which is widely done, it's about as much as 10% have adverse events causing us to need to discontinue. Infusion or injection site reactions, 3 to 20% infusion reactions with infliximab, particularly when someone has been off it and comes back to it. A true drug-related lupus-like reaction is 1% or less. Serious infections, perhaps 3. Skin, including other things such as a psoriasis-like reaction, is probably 1 to 2%, but other types of reactions are much more. Tuberculosis, though we screen for all of this, is exceedingly rare, and it depends on the population that you're treating. Non-Hodgkin's lymphoma, it's really more in the combination of an infliximab or other anti-TNF, adalimumab, plus 6-MP. It's probably, this is on the very high side. If you just have an anti-TNF, it's probably closer to 1 in 10,000 compared to the background risk, which is probably 1 in 20 to 25,000. And then there are a variety of other things which we'll talk about in a little bit more detail, because they're important to know, even if they're rare, whether it's a demyelinating type process, heart failure, or serious liver disease. So that there's, interestingly, a whole variety of autoimmune diseases that can be provoked by anti-TNFs. And it's perhaps one of the only things that really unifies this and causes it to be really legitimately called sort of autoimmune. Often we look at these things, so when we look at ulcerative colitis and Crohn's, we don't have good data to say these are genuinely autoimmune the way lupus is. And when we look, we can have a drug-induced lupus, we can have psoriasis, alopecia areata totalis. I saw somebody not long ago who went on to an anti-TNF and within a month had lost every hair on his body. That's slowly coming back, but slowly. Again, that's rare. Case reports, probably less than 1 in 1,000. Autoimmune hepatitis is probably a little bit more common. Sjogren's has been seen. We've seen that, and demyelinating diseases. Vasculitis is not uncommon. And we published a paper recently using collaborators in Denmark that people who are on an anti-TNF for non-IBD related for rheumatoid arthritis and other things, there's a low risk, but an increased risk of developing inflammatory bowel disease. So these are important to keep in mind. Each one of them is rare, but when you put them all together, it's probably the most common set of side effects that we see with an anti-TNF and the most poorly understood. Congestive heart failure is the other one that is not really seen as autoimmune, but it probably happens in particularly those who already have some degree of heart failure. When they did studies of class 3 and class 4 heart failure as a randomized trial to see if this would actually benefit people, it actually worsened outcome, particularly at the higher levels, and there was an increase in hospitalizations and even mortality. So we've taken that to really tell us that it's a very strong contraindication. If people have some degree of heart failure, they should not be put on an anti-TNF. There's a small number of cases that have been demonstrated in people who did not have a risk or did not have it already. And so that's worth knowing about in terms of safety of these drugs. So returning then to the autoimmune part, we can see here a little bit more in terms of more in female. This is a small, initially early on that we published of our initial experience in drug-induced lupus erythematosus, medium range, so they can be on it for quite a while, and median number of infusions. So it's not something you're necessarily going to see right away. Now we see here when they're retreated with a second anti-TNF, we've shied away from that now because it really happens in a high percentage. When it happens, if it's at least a longer term after, it seems as if there's a set of events that need to collide together to make this happen. And we would not give it now within 6 months. We like to wait if we've done a variety of other agents now that we have that opportunity that we didn't in 2011 when we did this study. And if it's a longer period of time, we can sometimes have people do this without problems and get back on it. So there's a set of things that need to happen which we haven't really fully understood. And again, here, these are the different antibody profiles that we see. And it's worth keeping in mind that ANA is going to be positive, and usually it's quite elevated. Anti-double-stranded DNA are going to be positive, and usually that's quite elevated as well. But anti-drug antibody is very low. So this isn't a reaction to the drug. It's a separate reaction that occurs. It differs from classic drug-induced lupus in some ways, and then there's female preponderance, which has been shown in others. There's a higher amount of anti-double-stranded DNA and some other things that would be used to try to separate these out as well. So it's important to recognize, because sometimes what happens most typically is people will say, oh, well, this is a complication of IBD. This is an IBD-related arthropathy. We just need to give a little bit more, maybe increase the dose, shorten the interval, and we're sure they're going to get better. And when the first person I saw, this is quite a while ago, who had this reaction, it seems to be, and this is more impressionistic, that the longer you continue on this without recognizing it, the longer it takes to get better and the worse it gets. So if you recognize it early, and it's really important to recognize that, it resolves more rapidly. We'll move on to our next case. We'll have questions at the end. So this is a very different kind of problem, 42 years as well. This is a man who had occasional reflux, more symptoms with severe symptoms of burning over the past 4 months. No weight loss. In fact, there'd been a 12-pound weight gain over the past year. Minor cough. and on omeprazole already twice a day, and amlodipine was added not too long ago. So what next? So the real problem is reflux that's been getting worse over the last 4 months. So a set of questions that are reasonable to ask the patient is, you're on a PPI, how many doses are you missing per week? So as we know, certainly when they did studies, this is a little bit different because someone not symptomatic, but of blood pressure medication, it was only about 60% of people that even filled the prescription. So we think we have a good relationship with our patients. We're telling them why they should take it. They leave the office. We think we've done some good. Now, this is a little different because this is something where someone's symptomatic and will be taking it probably more reliably. But even in IBD, some good studies suggested that only 60% of people take it appropriately 60% of the time. So the very first thing to check is, it's not necessarily yet a failure of the medicine, but is the patient taking it? And when are you taking them? So it's critical that a PPI needs some food to be more active. If you take it, say, at bedtime or in the morning and you're not having any breakfast, it's going to be a little less effective. So it's not that you need the food because you're going to get sick or have a stomach ache from it, as much as you need some food to make it a little bit more active. And so timing is important. And are you taking them before food? How long should someone be on it? Are they taking it for just a brief period of time and then they said, well, I took it, you told me to take it for 4 weeks, I stopped it? And certainly someone should be on it if they have evidence that they've been scoped and they have erosive esophagitis. A longer course is important. If there's not that injury that you need to heal, a shorter course can be fine. And as you know, we're trying very hard to get people off of these, and there can be this phenomenon of rebound acid surge. You're blocking all these pumps, these acid pumps, and so the stomach makes more and more because there isn't that feedback loop of saying you're making enough acid, and then you withdraw it, and suddenly there's this wave of acid, and so somebody feels like, oh, I really need to be on this drug. From a pharmaceutical perspective, this is a wonderful thing in terms of if you're trying to sell more drug. But if you're just trying to figure out what's happening with the patient, it can be confusing. And so often we'll go every other day. Sometimes people will add in the famotidine as you're trying to come off of this as something that's going to be milder and help someone deal with that sort of surge of acid that comes along. So they're taking it appropriately. They say, I take it just as you told me to. I take it in the morning before breakfast. I take it in the evening, about 20 minutes before supper, but I'm still having this. What next? So about 20 to 25% of people will still have symptoms despite being on BID. Some studies, maybe going for very, very subtle symptoms, go even higher. And so the first issue is, could this person be a rapid metabolizer? So that happens more likely with omeprazole or esomeprazole. And the one that tends to overcome this is rabeprazole. Now, we know that it's often hard to get insurance companies to cover this. In our area, some of the insurance companies are just saying across the board, it doesn't matter what the problem is, no more PPIs are being covered. And so that makes all of this a little bit more complicated. But that's certainly, if you have somebody that seems to be taking it appropriately and is still getting all of these problems, that's worth keeping in mind. And additional things, as mentioned, famotidine for breakthrough at night. You could do that twice a day even as well. And then if they're still having symptoms, it's a matter of checking a pH probe, because is this really acid reflux, or are you missing it and is this really more bile? Is there something else that you might be missing? So for bile, something like sucralfate may be much more effective, but it can be difficult to take because you've got to take it just after a meal and taking it as much as 4 times a day, but that at least can help. Is there something else, though, that's missing? Might you have gastric emptying delay, and that's causing more reflux because stuff isn't exiting? Less likely, but is it still a concern? Could there be a partial small bowel obstruction causing this more severe reflux? Or is it really not that, and there's just a visceral hypersensitivity that's developed over time? Now, 75% I think is on the high side, but some people have done studies to suggest that there's still some ongoing symptoms despite twice-a-day PPIs, and adding on the famotidine, as we mentioned, at night is reasonable. But what are some additional approaches for people who have still had problems? I think sometimes we used to rely more heavily on lifestyle measures. I think we've dispensed them because thinking we have these very effective medications. But keep in mind, these can be quite important still for the management of gastroesophageal reflux. So tobacco, coffee, chocolate, mint, fatty meals, bigger meals, all those can be problematic. And so elevating the head of the bed, not just so that their head is tilted up, but so that their body is up a little bit, can be helpful as well. As I mentioned, bile salt reflux and sucralfate can be very helpful. It can be helpful for acid reflux as well that's not responding. Then other anti-reflux measures, baclofen is something that is sometimes used as well, 5 to 10 twice a day. Some people even go to 3 times a day. And there's some work that's been done to suggest that can be helpful in reducing the reflux and coming back up and strengthening the esophageal capacity to manage this. So we ran through that rather quickly, and usually there are certainly more discussions there, but really please put down any thoughts you have or other questions you have, and we can go through those. So case number 3 here is a 74-year-old woman who's been complaining of having diarrhea, which is slowly increasing over the past 2 years, and seems to be sort of acute on chronic, worse over the past month. It's now up to about 5 to 7 loose stools a day. She had antibiotics for tooth extraction 8 weeks earlier. She had normal screening colonoscopy a year earlier. No weight loss at this point. And she is a long-term tobacco smoker, taking in about 1 pack per day for a couple decades. Has quit a couple times, but keeps on coming back to it. And here are her meds: hydrochlorothiazide, levothyroxine, rosuvastatin, omeprazole, and ibuprofen. So the question then to think about is which of these could be contributing to diarrhea as a way to start. So certainly when we look at these, really a physical exam is unremarkable. So when we look at what's our differential, what are the things that we're concerned about here? Certainly with the antibiotics, C. difficile is going to be important, and she actually got clindamycin, which is the one we worry about most, and it can give as much 10% of the time, can produce C. difficile. We worry about some inflammatory condition. Could this be inflammatory bowel disease? And we'll talk about that. We worry about medications. Is it functional? Could she at 74 be developing more of a functional problem? Is it diet related or other? So let's look through these then. So what's her risk for C. difficile? Well, certainly, as we mentioned, antibiotic, and plus PPI in itself is also a risk factor for C. difficile. It changes the flora. It reduces the acid barrier, so it permits other bacteria to get in as well. And C. difficile, not to be too frightening about it, but is in something like 50 to 60% of swimming pools and about 70% of streams. So we are exposed to it. It's at low levels in those areas. And we, though it's not, as you know, there's something about normal stool flora which protect against the development of C. difficile. Inflammatory, we would certainly want to look at cedrate, CRP, and calprotectin, ulcerative colitis, Crohn's. More likely, ulcerative colitis happens in an older population, but in Crohn's as well, there's a second little bump in the over 65 age group. And sometimes that can be misinterpreted as being confused with ischemia. And some of ischemia can be chronic, so that's something we worry about. Medication, certainly omeprazole, but when we look back on what they're on, rosuvastatin even, hydrochlorothiazide, and even PPIs can all be associated with diarrhea. It wouldn't explain the sudden worsening unless there's been a dose change. But keep in mind all those things, and omeprazole can be something that can, and that's specific to the PPIs, meaning specific to omeprazole, it's not all the PPIs. Functional IBS, and really there we're thinking about bacterial overgrowth, which is increasingly recognized as a problem. And then diet, we'll go into diet more. So we checked C. difficile, and that was negative. In terms of inflammatory issues, sed rate was unremarkable, CRP was normal, and calprotectin was normal. So that would say that it's not likely to be ulcerative colitis or Crohn's. We tried switching to lansoprazole, and that didn't make any difference. And she had bacterial overgrowth that was positive. So we treated her with rifaximin. We were able to get it through her insurance company. And as you know, there's been good large studies to suggest that 550 milligrams 3 times a day for 2 weeks does improve a subset of people. You can see it's not an enormous differential between the placebo and rifaximin, but it is higher. And the breath test is relatively easy. It takes a while, where they breathe into a machine, a little device, and every 15 minutes for up to 3 hours. And we see the rise of this, and it's much more widely available now. So she was treated with rifaximin for this positive thing, and it didn't really make much of a difference for her. So we then looked at diet, and there are a variety of things that are foods that increase gas production. Now, it's not all diarrhea, but that can be part of that as well, and so we look at that. And then more so the FODMAP diet. So this can be a significant source of carbohydrate malabsorption. I think most of you are likely familiar with this. It may lead to symptoms of IBS with possibly inflammation, but that data is a lot softer. And one thing that I think is critical to know about this, because when patients look at this, it's pretty daunting, but it's not meant as a very long-term diet. It's really meant as a diagnostic diet. And some people do it all out and then restrict which foods seem to be responsible. Or some people will take the different food groups in themselves or look and say, which of these makes sense? Monash University in Australia really put this on the map and really have the best website, I think, for this, but there's lots of availability, and people are widely familiar with this at this point. And so there are a variety of these different subsets. Dairy is certainly one of them. And it's very helpful to know which foods are higher in these, and restricting those certainly can make a benefit. Again, most people don't have problems with all of these things, but it's a wider set of foods that people may have difficulty with to sort out and can be effective. So that was done. Didn't have any improvement for any of these. So what do we do now? And she had a colonoscopy a year ago. So second opinion came to us, and certainly the screening colonoscopy a year ago had been negative, but unfortunately no biopsies were taken. And so we really worry about microscopic colitis, particularly in this setting. The colonoscopy looks normal or largely normal, and if someone's doing a screening colonoscopy and was having symptoms at the time, we always would want to have biopsies taken. Typically, it's sort of transverse and sigmoid, so the yield is a little bit higher. And we would want to repeat colonoscopy with biopsies. And sure enough, she came back as having collagenous colitis. Collagenous colitis is something that was sort of came into our world a little bit more recently than others, and then subsequently lymphocytic colitis. It's a chronic watery diarrhea. It tends to be normal or near normal in endoscopic appearance, and certainly radiology is normal. And some of the things that she had, like the calprotectin, is typically normal in this as well. So it's not a surprise, we don't rely on calprotectins to diagnose this. And it tends to be older people get this, fourth, fifth decade. Some of the literatures we'll go into is female predominant, but not all. And what's seen is this increased subepithelial collagen deposition. There's some question of whether there's a spectrum of disease from collagenous colitis to lymphocytic colitis. And certainly we've seen people also who start out as collagenous colitis and then evolve into Crohn's disease. So there may also be a spectrum there of disease as well. And so there's a question of whether they're really distinct entities or is this a spectrum of a single disorder. Tend to be middle-aged, but meaning we're pushing what that means as we all get older, 6th to 7th decade. There can be 25% before the age of 25, but that tends to be more lymphocytic colitis, not so much collagenous colitis. There's a female preponderance initially described, and we still think of it as that, but a review of all published cases, there's really not so much a gender difference. The risk factors are smoking and nonsteroidal use above all. So stopping nonsteroidals, we don't know if that changes the course, but we certainly would do it. And importantly, there's also no increased risk of colon cancer that seems to be associated with these diseases. So because of that, we're happy to get someone asymptomatic. We're not trying to eliminate the inflammation, but if we can, that is really preferred. So because of that, we can rely more on antidiarrheals than we would otherwise. Initially, bismuth came along as being a cure for collagenous colitis, but subsequent studies recognize that that may have just been patchy. So we'll still use this, but you can get bismuth accumulation, so we don't like to rely on this for long term, but certainly adding it in for a little bit. Some data to suggest mesalamine and sulfasalazine can be effective, but I'd say that in our experience, and maybe we're seeing people who are more sort of second or third opinions, that's not very effective, but we certainly give those a try first. There was a thought for a while that bile salts were the cause of this. And so bile salt binders at least can be important for symptomatic resolution. Steroids, and particularly budesonide, can be effective, but these are really chronic diseases, so we don't like to rely on these for too long. And then we'll use other biologics after we use immune suppressants. Methotrexate has some of the higher responses, but tends to be underutilized. And there's a growing body of literature, both for anti-TNFs or for vedolizumab in the treatment of this disorder. So important to keep this in mind. It's not super rare as people think, and this can be an important cause that is often missed. We're going to try to get through just quickly part of the last case. Actually, we have two cases. We'll run through this one quickly. A 27-year-old man with a year history of Crohn's ileitis, initially on prednisone, then infliximab, for 8 months at 5 milligrams per kilogram. And then after that, started having an increase in diarrhea, abdominal pain, and some minor increase prior to infusions, which then settled down. No other meds. Physical exam was normal, and just a slight elevation of CRP. So next steps. We certainly always worry about C. difficile. So people with inflammatory bowel disease will be at an increased risk, even if they haven't recently gotten an antibiotic. And we worry really here about loss of response to infliximab. Why does that happen? Well, people can have a protein-losing enteropathy with a flare, so they're just losing the drug quickly, or they can develop antibodies, and that's really what we worry about. So we want to check infliximab levels and antibodies prior to the next infusion. We tend to rely much more now on this kind of therapeutic drug monitoring than rheumatology has. And I would say that maybe we oversell how good this is, but certainly in extreme cases where someone has developed antibodies, lost response for that reason, this can be very effective and helpful. And so there's a low level of antibodies. The anti-TNF level, infliximab level here is low. We like it to be over 5, and some people push that even a little bit further, and a low level of antibody. Now, it's important, the level of drug is constant across assays, but the antibody level differs, and there are about 6 different assays that are out there being used. So it's important not to just take that as all or nothing. You can sometimes continue even if they have a very low level of antibody, but we worry about that. So with all the anti-TNFs, there's loss of response. Some of it can be because of antibody development, but not all of it. Some people, they're basically putting a block in the immune system, and the immune system is clever enough to find a way around it. So some people lose response because of a different predominance of the inflammatory process. But other people will lose it because there's loss of response because of antibody development. So you can see here, there's a high percentage. It doesn't mean that the drug is lost for all this. The beginning is adalimumab here. This is infliximab, and this is certolizumab. Sometimes it can be regained in terms of their response by tinkering with the dose or the interval. And roughly, we think it really comes down after the first year to be 5 to 10% annually after the first year. And there's a variety of reasons why people lose this. It can be you develop presence of anti-drug antibodies, the concomitant use of immune suppressants, even though in many cases we're getting away from that, can reduce anti-drug antibodies and increase drug concentration. Low serum albumin concentrations increases drug clearance. High CRP, we don't measure anti-TNF concentrations outside of a study, but those also can create a sink where the anti-TNFs are binding. High body size and gender also, particularly males, have higher clearance. So if you're starting infliximab for Crohn's and somebody who's a big guy who's got a really high CRP, you might even start it at the higher dose, 10 milligrams per kilogram, and then taper down over time following drug levels, because you may know that this person's going to need more and is going to get rid of it faster. Immune suppressants can reduce the risk, but again, there are other issues there, and I won't go into all that now, but slowly getting away from that. This was in the early days when we were using infliximab as needed, as opposed to on a scheduled basis. When you do it with continuous therapy, that's much, much less. And if somebody's on an immune suppressive and continuous therapy, it's very low. It's probably even lower than this, though, for just concomitant, continuous administration. We know that higher levels do correlate with better healing. And so we want to push that with infliximab over 5, and that there aren't specific guidelines for trough levels, but we have a set of guidelines of what we really look for, and 3.2 in some studies. And so we really push it to between 5 and 10 for infliximab, 10 to 15 for adalimumab, and others for the others are a little bit more. I'm going to jump ahead a little bit because I want to get to, there's data to suggest that proactive monitoring does make a difference. And in this individual, infliximab was increased to 10 milligrams per kilogram every 8 weeks, and remission was achieved. 8 months later, there was further loss of response, and now the level was 0 and a very high antibody titer. So we continued it only because the level was so low and the titers were very low. But if you have a high antibody titer, you're not going to overcome that. And then at that point, you want to go forward. Now, the importance of monitoring for loss of response is it's not going to change what you're going to do in terms of increasing the dose for that particular drug. But if it's positive, if they have an antibody that's positive, it means they're much more likely to respond to a second anti-TNF. And so then if there is negative, you can increase the dose. So it's important because if they have, it helps direct your next therapy. If they have antibodies to an anti-TNF, you can go on to a different anti-TNF and they're likely to get the response. If they're negative, they don't have an antibody, you can increase the dose or shorten the interval. We'll go as high as 10 milligrams per kilogram every 4 weeks for infliximab and get a continuous response. If there's no response to the second anti-TNF for antibodies, then we want to change to something that has a different mechanism of action. If there's a subtherapeutic monoclonal antibody concentration, you can increase the dose or frequency. if it's not that, you can change to a different antibody, as we've discussed. So we will try just to quickly run through constipation in just a quick minute. Someone who had colonoscopy 3 years ago, had an MI, was on ibuprofen, atorvastatin, metoprolol, aspirin, and taking some fiber. And again, ibuprofen can cause constipation. Metoprolol can, it's not common. And here, to keep in mind a number of things that can cause secondary causes of constipation.